Hey guys, my name is Divine. I'm a fourth year student, and I'm here to present the Year 3 Renal Revision Lecture for 2024. I like renal a lot. Although sadly, I think it's done a bit dirty in Year 3 in terms of the matrix. There's only a couple R1s, and to be honest, a lot of the content in assessment ends up getting weighted more towards your pathology studies. Of course, some of these topics you'll see a lot in placement. I guess the exam tries to sort of reflect that in some ways. So know the R1s, know the management, but I think by far the most helpful thing to think about is studying in response to approaches to presentations. It trains your lateral thinking for real life, but ultimately, all your exam questions, your multiple choice questions, will be arranged in such a patient in a clinical scenario presenting with a particular complaint primarily. And of course, your apexes are like that as well. So the idea here is that through studying with presentations, we focus on the big picture. We don't worry too much about specifics, and we don't think about, let's say, long lists of conditions and presenting complaints. We think much more about only the features we really need to rule in and out particular conditions. And at the same time, a lot of the maybe undersold sort of questions that, or sorry, content that we don't really talk about enough, are to do with what investigations you do first, or what is the gold standard investigation to diagnose a particular condition. And so again, when we train ourselves in approaches, we sort of can think about everything at once rather than distributed throughout, 10 or so different conditions, which was my mistake when I was studying. Here's your matrix. Like I said, I think knowing the R1s tell you what you need to know the management of. The R2s sort of tell you what you need to know the clinical features of. And then at the same time, we also have, I suppose, some other R2s in the scrotal and testicular disease sort of section where I think you're, again, more so thinking about just the clinical features. Pathology teaches a lot. I think glomerulonephritis ends up getting underrated even in your multiple choice exam because again I feel like a lot of the topics sort of come up again, but consider any of these conditions in the patient presenting with hematuria, urinary issues, abdominal pain, and some of the more vague presentations as well, such as in a weight loss fatigue sort of scenario you think about chronic kidney disease and of course fever, because of UTIs being such a common infection. And then other sort of related presenting problems, sort of hypertension, abdominal masses, more so for, I guess, multiple choice questions. But there are, through that, some other peripheral topics that might be important to think about. Bilateral renal artery stenosis being one cause for sort of hypertension in patients we wouldn't expect to have it. And of course, renal tumors for kids with abdominal masses, but we'll get into that later on. So I've tried to do this presentation by focusing on these presentations, seeing if you can group these matrix conditions into differentials for each presentation. And then, of course, specifics to do with each condition, going in order from acute kidneys, which I think are probably the most important conditions, group of conditions to know about, glomerulonephritis and nephrotic syndrome, which, again, you're taught in pathology, you're guided by that. But again, this comes up a lot again in your MCQ Qs, and then chronic kidney disease, and then finishing off with prostate and testicular pathologies. So what do I exactly mean by presentations? Here we go. Here's an example. Have a read. The idea is that you should have certain differentials in mind, and if you don't, then this might be a topic you might want to read up on in a very comprehensive source. So for hematuria, we can kind of divide the differentials into glomerular causes and non-glomerular causes. Glomerular, of course, being glomerulonephritis. Probably the more common ones you're working with are causes of nephritic syndrome, such as IgA nephropathy, post-streptococcal. And then I suppose you're thinking non-glomerular, so we're thinking about UTI, calculi, and sort of issues to do with the kidney itself. So polycystic kidney disease. And then lastly, red flag differentials, which you should always have. That's why we're really learning them, right? So cancers of the renal tract, cancers of the prostate are ones that are particularly important. And then I think bladder cancer kind of gets underrated as well. but it's important, I suppose, because its clinical features are quite distinctive in a way. Um, Lastly, we have investigations. So again, rather than thinking about investigations for each condition, I feel like it's much more helpful to think about them for a presentation because you'd pretty much always be asking the same questions for a patient coming in with hematuria. And more, and of course, you're weighted by your clinical judgment, but the idea is that a lot of the investigations you do might end up being the same for most groups of patients. So we have FBE, UEC, ESR, glomerulonephritis screen. For imaging, we think about our differentials and we choose the imaging most likely for that differential or the other sort of workup pathway, depending on what it is. And finally, special tests, you're quite commonly using urine MCSs and dipsticks, PCRs for, again, thinking about infection, quantifying the blood, etc. So this is the kind of thing I've done with for some the other sort of presentations. Again, so here's an example with hesitancy. So I wonder what this could be. 60-year-old male with urinary hesitancy, weak stream, incomplete bladder emptying, enlarged prostate, but non-tender. So a lot of our differentials to do with hesitancy or to do with obstructive causes and to do with, I guess, like your conditions, you're mainly worrying about a cancer of the prostate or BPH in men. But then the other idea here is that there are other causes of sort of outlet obstruction, right? And so one that's not on your matrix, but might be relevant if the other features aren't as convincing, could be something like a urethral stricture. And so again, through thinking about presentations, we come up with, or we think about things that are not on the matrix explicitly, but I guess how I would like to refer to it as like the secret matrix. And you'll see certain conditions like this on your past exams. Sometimes it might just be a difference in curriculum. Maybe the matrix might have changed, but don't be alarmed if there are topics that aren't explicitly on the matrix. Focus on those matrix conditions, know how to exclude them. And if the picture doesn't match one of them, then it's likely something else. So for hesitancy, a similar set of investigations, of course, probably the main one we're now adding in is PSA, and although we'll think about when and when we may not order this later on. And then in terms of imaging, some of the interesting ones that get added in include the idea of urodynamics or trying to obtain a post-void residual volume to quantify the amount of urinary retention someone has. And then next to dysuria and frequency. So 32-year-old female with dysuria and frequency, suprapubic tenderness. I wonder what this could be. Well, our differentials are varied, but of course, for dysuria and frequency question, like scenarios, I guess, we're mainly thinking about UTIs, but I've added in some other interesting causes that you might want to think about that wouldn't be relevant. So how would we exclude diabetes in this case, or another cause for frequency, endocrine? And what about neurological issues that could contribute to this sort of issue? Although, again, our bloods will be the same sort of for these scenarios, right? So we might add in blood glucose levels as well because of the fact that diabetes is one of the differentials. So again, rather than trying to remember everything individually, we're trying to think about broad sort of approaches and what we would do if that patient came in and we're in ED or something like that. Testicular lump and pain is the last group. So let's not forget about them. So 25-year-old male, sudden onset testicular pain. And I feel like questions you will eventually get asked are a lot like this, right? So they're clearly written with a condition in mind. Most of them will point to a particular diagnosis. The main idea is that we should be able to identify them in association with each other, have the differentials in mind, and then know what else we want to know to rule out the other conditions that we're worried about. I suppose the other idea to add on to here is that in terms of types of exam questions we can get, again, there might be strict diagnosis like this, but again, we can split up our differentials in many different ways. This is a good way that I found, and this is credit to the last year's renal lecture for this, and for a lot of the other slides on this actually, on this presentation. But I guess everything except what I've crossed out could be something that is sort of matrix related, right? Or pathology related in some way. And so maybe pain and painless. So we're thinking painful, sudden onset, it's one of these, probably testicular torsion, which is one of our conditions on the matrix, compared to gradual onset, which is more so a sign of infection. So again, a question could be very easy in the sense, not maybe easy, but diagnosis related. We might have a question that's more investigation related. Of course, you again ordering a similar set of investigations every time if someone has this kind of issue, although the most important investigation will be related to what we think is actually the cause. Although that's why we got to now go back to the specifics of this matrix condition, because sometimes imaging might not actually be, for example, needed, even though it could be used in a case where we're not sure. So that's why we got to, after going through all this in general, we got to go through each individual condition. But yeah, some things that we've need to add in here. So STIs and I guess aren't really as talked about as much in year 3, but still relevant to mention in like an apex. Other sort of infection screening, mumps in the case of testicular lump and pain as a cause of infection. And then thinking about we have ultrasound in here, and then some other sort of, this would more so be a bedside test, but transillumination, for example, in order to think about, when thinking about, hydrocele. All right, let's keep moving. So now we're talking about acute kidney pathology. So think about your matrix. First up, acute kidney injury. Now, the reason why I've tried to talk about this first is because almost, but as you would have learned about in hospital and in your own learning, most roads lead to AKI. And that can be from many different conditions. And we'll talk about causes in a second. I think understanding the definition is helpful. And so how we mark it. And again, presentation broadly. So it'd be great if you could list and rattle off all the different symptoms. I think you probably could and should. But I guess something to think about is that, again, we probably wouldn't be asked to name a symptom. They'd be given to us in a cluster. So in that sense, recognizing it that way is important too. I think this is helpful, again, in the more lateral thinking sense. And I think it's just the basics of what we got to know for AKIs. And you'll be probably asked about this in hospital at some point. But as you may know, AKI causes can be split into prerenal, intrarenal, and postrenal. And the idea is that it's generally to do with either blood flow to the kidney. So that's from systemic issues, sort of, and actual kidney damage itself. That could be glomerular, that could be interstitial, that could be tubular. And the main causes we're thinking are drugs or some other primary sort of like glomerulonephritis. And then lastly, the idea is that we might have outflow obstruction that causes kidney damage as well. So generally, the idea is that we can split this into below and above the bladder. So causes above the bladder, like renal calculi, whereas urethral strictures would be below. And so associated ideas to do with this include hydronephrosis, and being able to think about, okay, what would happen if a patient came in with hydronephrosis might be something that would be a bit of an extension topic that, again, you would want to think about maybe for a multiple choice question. But the idea here is that, again, someone has an AKI, it's helpful to think about what specific investigations might be helpful. Apart from the investigation we've talked about already, some bedside tests that, and credit to last year's renal lecture for this, some bedside tests include thinking about complications of kidney injuries, as well as causes. So electrolyte disturbances are important here. An interesting point might be thinking about an ECG because electrolyte derangement may cause arrhythmias. And then some special, or maybe not special, but particular tests that might be relevant. So we might think about our creatinine levels, as well as our blood urea nitrogen creatinine ratio, which can help us differentiate the cause of AKI. And then thinking about the management now. So of course, the idea is that we want to reverse the cause or treat the particular cause. And in many cases, that could be drug related, right? So we want to do a medication review, and some drugs to consider include ACE inhibitors, NSAIDs, and diuretics. We think about the triple whammy, and we would have learned about that last year. And also in terms of fluid management, so the idea is that we might want to correct, for example, fluid disturbances, but at the same time, in someone with kidney issue, we might want to also think about kidney fluid restriction and other causes, in the sense that they're not able to filter properly, and so they go into fluid overload. So probably if I were to remember any specific thing about AKIs, it'd probably be the management of, let's say, the complications, because management related wise, this is probably the most specific, and you wouldn't be able to just get away with your general sort of first principles. Thinking about complications. So again, fluid over leading to pulmonary edema. So the things that we'd have learned in the context of heart failure would be relevant. Metabolic acidosis, we need bicarbonate, hyperkalemia. And so you may have heard of similar ideas in other sort of conditions to do with hyperkalemia. But we think about things to decrease the actual calcium levels, as well as also thinking about sort of consequences of that. So the idea here is that you might give dextrose and insulin as to push potassium into cells, but also maintaining the patient's blood glucose too. Hyperphosphatemia and AIOU. So AIOU tells you when you would consider dialysis for someone with kidney disease, and that's in acidosis, electrolyte derangement, intoxication, drugs, fluid overload, and signs of uremia, of which we have altered mental state, pericarditis, and asterixis. So the idea here is that, and this relates to renal replacement therapy, but this knowing when to do things, more so than dosages or anything like that, is most helpful because that's really how, I guess, exam questions would be structured, right? So again, just on thinking about differentiating pre and post-renal causes of AKIs, the kind of idea is that we can think about the differences in how they affect electrolytes, particularly sodium, as well as creatinine. So in the pre-renal AKI, remember, it's a systemic issue. The idea is that the kidneys are still functioning well, but we need to compensate for their injury. The kidneys will compensate for the injury to them because of systemic hypertension and such. And so they'll concentrate urine. And to do so, they'll reabsorb water, and sodium goes with water. So the idea is that our urine ends up being hyperosmolar. So the idea is that high in many other metabolites because it's very concentrated, but low in sodium. And then the idea here is, again, because of our kidneys being functional, urea, again, will follow water. So we'll have relatively higher urea in our blood compared to a post-renal cause where we have actual sort of kidney damage. Again, think hydronephrosis. The idea here is that it's the opposite. So we'll have loss of filtration of metabolites out of the blood. So our blood will have lots of the metabolites, but our urine won't. So we'll have hyperosmolar urine and then high sodium in our urine because we've lost our ability to retain water. And then likewise, we aren't able to resorb urea, so we'll have low urea in our blood. This is helpful because, pathology involves many things, not just, especially not just, let's say, histology, which is what you've been doing a lot this year, but also just to do with like tests, blood tests, x-rays, etc. And so renal pathology is interesting because it's a lot to do with obviously urine, and we don't talk about that too much. And sometimes we kind of oversimplify things, but I think for the case of your exam, that's fine. So when we think, I think it's kind of self-explanatory in some case. Protein means there's protein in the urine. Red blood cells means there's blood in the urine. Why? Because of nephrotic syndrome. But thinking about some other causes that might be relevant. So muddy brown cast makes us think about acute tubular necrosis, protein cast, multiple myeloma, hyaline and granular cast can be general signs of kidney damage. And in a similar way, white cells tell you general inflammation, potentially inflammatory from infection, but maybe otherwise as well. Okay, urinary tract infection. Again, you would have seen this all the time. The main thing, I guess, conceptually that I think is underrated is the idea that different parts of the tract can suffer from such infection. And so cystitis is distinct to pyelonephritis, for example, or urethritis as well. And so their presentations end up being different. So for pyelonephritis, it's more of a serious issue because it's higher up and our kidneys are connected to our blood. So we're thinking even worse in terms of like sepsis. So that's where rigors sort of come in, nausea, vomiting, and notably back and flank pain because that's where the kidneys are, compared to cystitis where you get more suprapubic pain because that's where the bladder is. You get dysuria and frequency more so in cystitis. Although depending on the population, this presentation is unreliable, as you may know, in the elderly and in kids as well. You might think about and Murphy sign, cluster vertebral angle tenderness, something to think about for UTIs. I think causes are helpful, more so in the most common ones, so E. coli in most people, and staph physicus in young females. But I think you may or may not have seen or heard of this association between specifically Proteus mirabilis infection and Struvite kidney stones. And we know stasis is the basis for infection, so stones are a particular risk factor for having a UTI. Other risk factors include, again, being female because of their different anatomy, diabetes, structural issues in children like vesico-uterine reflux, which is an issue with the way in which the ureters connect with the bladder. And although again, I think from scanning through most of these, I think for most of you, this will make sense. recognizing these risk factors in a question stem to help you think of urinary tract infection is the idea. As with why, that's why you kind of learn risk factors in general, right? Or in an apex scenario to kind of get more, maybe not get more marks, but have a more comprehensive history, let's say, by inquiring into some of these risk factors too. So again, in someone with this urinary frequency, we've already talked about what investigations we'd order, but here are the important investigations with UTI, specifically what's diagnostic. So the idea is that we're looking for a midstream sample that shows on culture more than 10,000 units of bacteria, basically. And there's some specifications to do with exactly how the culture should have been arranged. Note that the idea here is that the longer since the sample, the less reliable this gets, essentially. And then on top of that, some of our other tests may give us a better indication of either infection or sepsis. Procalcitonin is a general sign marker of bacterial infection, just so you know. And then management. So I think the prevention and sort of conservative management is kind of like up in the air, but I think it's important to know to counsel patients. Probably what you're looking for is what antibiotics. So Bactrim or Augmentin is like first line, or nitrofurantoin if they're pregnant, but that is not really a year 3 thing I think you have to worry about as much. And then IV, essentially, gentamicin or amoxicillin if they have severe pyelonephritis. So really it's about choosing the right agent. Doses don't matter. Let's keep going. Kidney stones. So yeah, I'm not sure why I wrote that. That should not be there. But the idea here is that, yeah, risk factor is being male. We'll stop. The idea here is that we think about causes for stones, and we'll get into that in a second. But the point is sort of metabolic issues in general can cause accumulation of, again, a particular metabolite. So you think gout, hyperuricemia might be a risk factor for uric acid stones. Dehydration, and probably the main and actual risk factor is diuretic use. Most of the other ones are kind of up in the air. And of course, like we said, if they have a UTI or Proteus mirabilis infection, this makes you think of Struvite stones. Presentation, again, if you have a broad understanding, then you'll be able to recognize this in the question stem. You'll also be able to recognize it once you think about unilateral flank pain, you're probably thinking about, again, renal stones, and that helps you with your history. But the real idea here is that the sort of peripheral topics, let's say, and pathology topics, I guess that's what I wanted to say, can be helpful here to think about. This is something that you might have learned in year 2. The idea that we have particular junctions in which stones are most likely to get caught, at the pelvis, crossing the iliac artery, and at the bladder as well. And the idea here is that there's different types of stones. I think again, this is a pathology topic, still relevant and helpful, but more so in thinking about risk factors for someone. Clinically, a lot of this kind of gets up in the air because, I mean, most of the time they don't really figure out what stone they have. But we can have calcium stones, uric acid stones, Struvite stones in the context of infection. That's where Staghorn calculus comes in, and cystine stones. But probably the main thing to think about is, and maybe exam relevant, is the idea that different stones are visible in different imaging. So the idea is that it's the calcium stones that you can see in X-ray because they're made of calcium, like your bones, so they're radio opaque. The other ones you can't. And yeah, so in real life, people probably won't order imaging as such, except if they're worried about other causes or insides of kidney damage. But you would be ordering a non-contrast CT of the kidney tract, and there's a point that I've seen that you may think about less radiation-driven imaging in children or people who are pregnant or people with recurrent stones, because while ultrasound might be less accurate if you're already, again, either don't want to go through with that because you already think it's a stone or they've had it before, that might be helpful. And also hydronephrosis too, but yeah, non-contrast CT-KVB is gold standard. Management. Pain relief, of course, probably, again, what is most relevant for you to think about is when you would do this or when you would do the other thing. So you'd always give the first line, but the idea, or first stop point, sorry. But depending on the stone, there's an idea that you might think about managing this medically or managing this with an intervention and urology referral. So tamsulosin, which is an alpha blocker, helps to relieve muscle spasms and help and promote stone passage. So you might consider that if it's a relatively smaller size, the tamsulosin. It might be worth knowing the second line of nifedipine, and you can't give tamsulosin in certain instances, such as if they're taking a different alpha blocker. And then large stones, again, you want to be really want to make sure you get the stone. So if they're concurrent infections, so that's why you might stent or do nephrostomy. But there's other options as well, like laser and shockwave with lithotripsy. But probably I think the idea is that they distinguish whether or not it's big enough or likely enough to pass by itself. So whether or not you need to refer to urology, like get a particular intervention, basically. All right, so we kind of sped run through that, but that kind of shows you exactly what to focus and not to focus on for your kidney studies, which again, compared to other systems, might not be as relevant to go into super depth with. Glomerulonephritis is a massive pathology topic that actually ends up coming up again. So if you learn it well in pathology, you're gonna thrive here. And again, thinking about presentation and investigation and stuff like that, we think about them in broad sort of approaches, especially because it's not, apart from the actual histology, there's not really much else that would distinguish between them. And that's why we have something called a glomerulonephritis screen. But the idea here is that the nephritic syndrome is characterized by hypertension, hematuria, and edema. And here are the causes. And if we know what causes nephritic syndrome, then that already starts to help us rule things out. So IgA nephropathy, you've heard of this before, I'm sure. The idea is that it's a nephritic syndrome simultaneous to or right after a mucosal sort of infection. And the idea is that in that infection, you'll have circulating IgA antibodies that won't get cleared by the liver and deposit in the kidney. And again, the presentation for most nephrotic syndromes are the same, but nephritic syndrome, sorry. But the idea here is that you might think about concurrent infective symptoms, like runny nose, cough, headache. Often is recurrent, and I think like cola or like hematuria in this context and that self-resolves is kind of like what we think about with IgA nephropathy. Investigations, I've included here what you would have seen on the pathology. Don't be alarmed because a lot of these words do sort of come up again, I think. But again, you learn it once well, maybe not once well, but you learn it well for pathology and it helps you here. But again, just to remind you, the idea is that we have mainly 3 different types of investigations, light microscopy, electron microscopy, and immunofluorescence. And for each individual nephritis or nephrotic syndrome, the idea is that we'll have different sort of presentations. But the idea is that you're mainly thinking about mesangial deposits of IgA and complement. I've included the management here. It's R2. I probably wouldn't worry too much about it, but I think it's helpful because it gives you first principles. Because most kidney damages are really about reversing the cause. And if you can't, protecting the kidneys for as long as you can. So that's where ACE inhibitors are helpful here and anything sort of hypertension associated. And that protects your kidneys too. So most of the time you'll be prescribing that. And in the case of inflammation in the kidneys, then you might consider immunosuppressants or steroids to help prevent progression. But again, for most people, this will resolve spontaneously. And I've just kind of included that because these are the sort of principles that I think would be good to think about last for a lot of these other topics as well. Post-strep GN, as it says, is following strep A infection. The idea here is that we now kind of want to think about what includes or what is the connotation of strep A infection, let's say. So we're thinking of anything to do with a pharyngitis, a skin infection, those sorts of things. And the idea here is that it's because of immune complexes. Again, so granular deposits of IgG, starry sky appearance, hum-like deposits of immune complexes. These are the things to do with post-strep GN. Again, all these topics can come up again on your multiple choice, so don't be alarmed, and not necessarily relevant to pathology, because remember, pathology is anything to do with like blood tests and x-rays and all that too. Anti-GBM disease, the idea here is that it's a pulmonary renal syndrome. Well, sorry, actually, I correct myself. I made the point here that this eponymous name, good postures, is a pulmonary renal syndrome and involves both. When we think about anti-GBM disease, it's the same thing, but without lung involvement. And what is that? It's the idea that we can form antibodies against basement membranes. Again, there's an alveolar basement membrane. That's why it affects the lungs, but there's a basement membrane in the kidneys, so, in the glomeruli, so that also gets affected, causing nephritic syndrome. You think about hemoptysis cough dyspnea. In the case of pulmonary hemorrhage, that tells you it's good postures. That makes you think about this whole thing. But apart from that, it's really just nephritic syndrome, and we'll get into this, but rapidly progressive GN. So, in terms of investigations, again, similar sort of ideas. The main things you're probably thinking about are chest X-ray for the lungs, and then you'll see linear staining of IgE deposits, and that tells you everything. The ribbon pattern maybe as well relevant. But yeah, whoops, that's that twice. So we also have ANCA vasculitis, which we'll get into in a second. But just overall, the idea here is that, and again, probably more rare, but on light microscopy, the idea is that we're thinking about granulomas, really, granulomatous disease, plus or minus eosinophils. But what actually is this? Let's maybe start here. There's a group of 3 different vasculitis that all get classed together. What I'll flag here is the idea that the idea that we have sort of modern ways of describing their of C ANCA and P ANCA. But the idea here is that some are positive only in some of the disease and some are positive in the other. I'm not sure if it's really as relevant or helpful to really dive in here. But I think, again, understanding the broad presentations are helpful, and maybe this, because it allows us to diagnose this in an exam question context quite easily. So what are we looking at? EGPA is eosinophilic granulomatosis or polyangiitis, otherwise known as Church-Strauss syndrome. But the idea here is that it's eosinophilic, right? So allergies, allergic, sinusitis, asthma, all that, plus nephritic syndrome. And I would probably call it a day there. But you can also get a rash and heart and lung involvement too. Other things like nasal bleeding, but I would most associate that with our next one, which is GPA, I'll say. So the idea here is that we're thinking chronic sinusitis, non-allergic related sort of rhinitis, nasal discharge, bleeding as well, and then also saddle nose deformity, plus nephritic syndrome, and then I call it a day. Because apart from that, it's hard because all of them sort of involve the skin, all of them sort of involve the lungs. MPA is the last one. The way I remember it is that it doesn't have nasopharynx involvement like the other two. And again, I would probably call it a day. Alport syndrome, relevant because it's a it's a pathology topic. I think thinking about sensorineural hearing loss in the context of nephritic syndrome points you in this direction, and thin basement membrane as well. That's all I got to say on that. And finally, I think just conceptually, it's helpful to think about rapidly progressive GN. So the reason why I brought this up is that we want to think about when in which we would have a case of rapidly progressive GN, sorry. So the way I've clustered it is mainly most anti-GBM, anything immune complex related, so post-strep GN. Most of these causes will result in this. But we would definitely want to prevent that, so we'll intervene early. I include lupus nephritis and membranoproliferative together because they kind of cause nephritic and nephrotic syndrome in a way. Lupus is known for the full house sort of immune complexes and the wire loop appearance, obviously relevant to SLE, and is a severe cause of, it's actually a very notable cause of kidney damage in SLE. People with SLE really think about this. And membranoproliferative GN, so Champ-Shack appearance, and some risk factors, including sort of infection and other hereditary causes, which might point you in this direction, but I think the pathology will help you the most. Okay, so again, when it comes to this whole nephrotic GN stuff, the main takeaway for me is that all these topics can only really come up with the pathology related for a reason, primarily because of the idea that you can't really distinguish them all on presentation, right? So apart from like some of these like IgA, nephropathy, stuff like that. And that's when it gets easy, right? Nephrotic syndrome, different. It's about proteinuria, more than 3.5 grams a day, resulting in these complications, but mainly edema and hyperlipidemia. So we're thinking about these diseases, and it's a similar sort of pattern. We want the broad presentation and something to think about it with it and the pathology. Most of the time, again, you can think about it's very similar to nephritic syndrome. We treat the cause, we suppress the inflammation, and we address hypertension or protect the kidneys with ACE inhibitors. Minimal change disease, you relate that with children, you relate that with idiopathic generally and transient and response to steroids. It's from podocyte damage, lose foot process attachments, and then you leak protein into the urine. Investigations, it's foot process effacement, and you treat it with prednisolone and has a good response. Membranous nephropathy, I want to flag the idea that it's related with solid tumor malignancies like lung and prostate cancer, as well as some other things. These are secondary causes. And we're mainly thinking about granular, again, IgG, and thickening of the basement membrane, and the spike and dome appearance on an electron microscopy, because this is immune complex mediated. Next, focal segmental glomerulosclerosis, kind of like minimal change, almost. It's foot process effacement, but it's focal and segmental. So not every biopsy you have might have this, just because of the fact that we have sampling bias going on. It's a very actually common cause of nephrotic syndrome in adults. It's actually can progress to end-stage renal disease. Sorry for including this twice, but there might be a triggering event like infection. Amyloidosis, relevant because Congo red staining, and that's kind of it. And next, let's move on to chronic kidney diseases. Particularly, the reason why I'm kind of flying through that transition is because the first one is to do with pathology as well, diabetic kidney disease. So it's kind of like a nephrotic syndrome. It's albuminuria in the context of a long-standing diabetes diagnosis, and of course, reduced eGFR. Here's some important causes to think about, but also risk factors. But I think these are all metabolic related and kind of explanatory. The idea of the presentation is that it would probably be alongside other, in the context of a question, other signs of severe, long-standing diabetes, so retinopathy and neuropathy particularly, and then other, again, general signs of diabetes that you would have seen in other cases and you would have learned about in other lectures. And so we can kind of move on here. And in terms of investigations, again, relevant in it's relevant in the multiple choice scenario as well. The main thing that you would have seen before is the idea of Kimmelstein-Wilson nodular glomerulosclerosis on kidney biopsy, but really, why would you biopsy them if you know they have diabetes anyway? And the idea is that you might think about measuring the actual albuminuria with either albumin-creatinine ratio or 24-hour. People don't do 24-hour collections, really. And yeah, management, control of diabetes, really. SGLT2 inhibitors are renoprotective, control hypertension with ACE inhibitors, and then manage the diabetes and cardiovascular disease and metabolic syndrome and all that. Chronic kidney disease. Again, another example of when knowing the broad presentation, which is inherently very vague, isn't helpful, but I would probably focus on the complications. These complications are super, super helpful here to think about. And also for taking comprehensive history. So, main complications that you can see on the exam: edema, pericarditis from uremia, anemia, and neurological changes as well. So causes, pre-renal, renal, and post-renal, and some other ones as well. Again, we mainly think about hypertension from varying causes, diabetes, and then lastly, chronic sort of obstruction and hydronephrosis. And then complications, we think about cardiovascular diseases, pulmonary edema, hyperkalemia, very similar to AKIs in the acute sense. And this is where the idea of acute and chronic kidney disease kind of comes in. But the main thing we're thinking about here are advanced and chronic complications. So anemia of chronic disease from decreased erythropoietin production, bone disease from changes in vitamin D metabolism, metabolic acidosis, hypertension, and uremia. And the idea is that one thing that's helpful is to think about how you manage each of these rather than worrying, I guess, all too much about that specific presentations. A lot of this is, I don't like to say self-explanatory, but I think if you could probably test yourself and you would know how to manage this from knowing about other chronic diseases and heart failure and stuff like that. But what I'll focus on here is the idea here that Again, we would mainly try and manage the complications. Think about fluid and diet restriction of potassium. And then lastly, thinking about sort of that like renal replacement therapy and of course end stage sort of transplant. We'll talk about renal replacement therapy in a second. Another reason why people might need renal replacement therapy is polycystic kidney disease. Again, understanding or knowing the broad presentations for the dominant and recessive the variations are important, mainly in the idea that dominance for adults and recessives for kids. This is mainly diagnosed in infancy. It can be diagnosed in like antenatally as well, so before birth actually. And then on top of that, for here we have just sort of general signs of chronic kidney diseases. Nothing that's really specific, but again, this is relevant in a hematuria setting, right? Whereas here's more like an abdominal mass sort of setting, and other sort of features that just would be abnormal in childhood too. Etiology might be helpful, but you know, again, it's sort of up to you what you want to remember. The idea here is that probably the main thing to think about is complications, because of some interesting and relevant points. So the idea that they have cysts sort of everywhere, and other sort of vascular issues such as berry aneurysms, which may lead to subarachnoid hemorrhage. So that's a very severe complication, of course. Mitral valve prolapse is another sort of thing to think about. Diverticulosis, hernias. And in terms of management, probably the only other thing that we haven't sort of relevant made mention of, and is probably particular to polycystic kidney disease, is 12-10, the idea that we can give a vasopressin basically to lower cyst production and preserve the kidneys. Renal tract cancers, again, hematuria related. Painless hematuria in the context of smoking, dye, occupational dye sort of exposure, bladder cancer, really. Nephroblastoma is a kid with abdominal mass. Renal cell carcinomas, most commonly clear cell. They're all kind of similar, intermittent hematuria, flank pain, flank mass. I think a lot of that is sort of explanatory. The particular features, though, pathology sort of related. You're probably not going to actually see someone with birth hog-Dupe syndrome in an exam setting. So I would say if I were to use the word, it's probably low yield. But learn it as you learn it in pathology, essentially is what I'm trying to say. Really, you'd only, in the clinical sense, which is probably what your exam is more about, there's not much to distinguish between these without pathology. And yeah. Renal replacement therapy, think about indications, severe CKD, and then also AEIOU and AKIs. And then you have two different options, really, apart from transplant, so peritoneal dialysis and hemodialysis. Here's a table sort of comparing the two. Probably the main thing you're thinking about is the fact that you can do peritoneal dialysis at home, but you worry about infection. And this is a separate topic in sort of gastro that you should, hepatobiliary, I suppose, that you might want to also relate that to. But spontaneous peritonitis. And so I'm just trying to think. I would flag there would be other things I'd flag, but I think understanding the difference in terms of like when you might do them is probably the most important thing. But the point is probably more so that what the advantages, you're weighing up the complications of each, basically. And I doubt they'd ask you to choose one for a patient because I think, this is like probably a specialist decision anyway. Prostate. More R1s. Again, I think a lot to do with BPH is probably heard of, but I think distilling all the urinary symptoms and actually coming up with a reason why they happen is helpful for you for long-term memory and just understanding. Maybe the only other thing I'll flag here is the idea on DRE, symmetrically enlarged, smooth, firm, and non-tender prostate with rubbery elastic texture, and distinguishing that from cancer. The idea that this comes from the middle transition zone of the prostate. So that's kind of why we get a lot of these urinary symptoms. And then lastly, the idea that sort of some complications probably are helpful, but really the concept here is thinking about the workup and a lot of the time and management. A lot of the time, again, they might say what investigation you should order first, what's the gold standard investigation. I think getting a sense of what is clinically diagnosed and what isn't is quite helpful, I think. the idea with PSA, and in summary, is that free and total PSA and the ratio between them, first of all, help us give a sense of, is this more so cancer or not? But really, the idea is that we can only distinguish them in biopsy, of course. So decreased free PSA, meaning decreased ratio between free and total PSA, is indicative more so of malignancy. So we will want to biopsy even more. If you have high free PSA, and a sort of increased ratio to normal ratio, then we're thinking more BPH. The only other thing I'll add in here, these are sort of helpful to think about in what you'd rattle off in an apex sense, urodynamics and avoiding diarrhea and stuff like that. Clinical scores are helpful, but there's some different ones, and so I don't think there's. I doubt. I'm not sure if there's any particular one that flagged to you, but I think I remember this from our lecture. And then lastly, for management, what I would think about is non-pharmacological, I think I think generally you can read that almost. But in terms of the options, again, when you would use each is helpful. I think understanding that really what we would be doing is a combination between an alpha blocker and reductase inhibitor. So that's what Deodar is, like tamsulosin and dutasteride or something like that. Is it? And understanding how they work is helpful. So, for example, this is 5A reductase inhibitors, reduce DHT, which is part of potentially the pathogenesis of like BPH. But then thinking about the side effects are helpful as well. So hypertension, sexual dysfunction, that's what mainly what we're thinking about. And of course, TERP is like, I guess, definitive. Prostate cancer, differences between the presentation of this and the other one, we're mainly thinking about cancer symptoms, weight loss, lethargy, and then signs of metastasis, like back pain. Those are probably going to be how you distinguish them, as well as DRE, hard, craggy prostate with peripheral mass, and then anemia and lymphadenopathy. Complications, mainly thinking about metastasis to the bone, liver, and it's just surrounding organs as well, lung. And think about how metastasis to the bone may present as a fracture, actually, instead. For prostate cancer, grading is, again, and staging, I think, is less relevant for you, but for med school, you see. But I think I'm going to include it as well because it is probably important. It is important in real life. But the idea of me bringing this up is it's mainly to think about when we would order PSA testing in general. So you think prostate cancer is suspected. You have if it's suspected, it's gonna we can do something about it. Basically, it's the idea. And then they're suitable for. So this is a lot you'd learn in like sort of screening, topics that you've learned about in the past. But it's really not like a routine test for anyone, just especially men, like that just happens to have like hesitancy and stuff like that. Yeah, so you do it if you think they have cancer. It'll probably be elevated, but it could also be elevated in other sort of issues as well, prostatitis, like bike riding, stuff like that. So really what we're doing here is thinking about, okay, is the presentation making me worry about prostate cancer, and so do I need a biopsy? So we'll do that transperineal or transrectal, and that's to confirm the diagnosis. And then you can think about bone scan for metastasis. Management, there's a couple things to think about here. Well, first of all, think about this credit to last year. So lifestyle, bone health. The pharmacology that I probably again would think about is like androgen deprivation therapy. But I think the idea here is that really for cancer, just full stop in general, like it's really just thinking about, is it curable, is it not curable? And then as a result, what can you do about it? So sometimes if they have a low life expectancy, you might watch and wait. If it's something you can do something about it, or they're young, you might do try and do prostatectomy. But in general, the idea is that if it's locally advanced disease, we're just trying to suppress it. And yeah, lastly, testicular pathology, and then we'll wrap up. So here are some of these conditions that we got to learn about, particularly hydrocele is on your matrix. The other ones aren't, well, tumors are on your matrix as well. But you can kind of think about the idea is that really, can we distinguish them from each other? That's what you should get out of this. And there's some other topics that again come up that won't be explicit on your matrix, but you would want to be able to distinguish as well, namely spermatocele, hernia, varicocele is talked about a lot, not on your matrix. And so we just want to distill all that as to what features we need to know if it's this or that. Testicular torsion is important. Adolescent with sudden onset testicular pain, nausea, vomiting. Think about the features on exam: absent cremasteric reflex, negative Pren sign. So you might have heard about this. So elevating the scrotum doesn't actually help with the pain. But a particular risk factor that's helpful here to think about is bell clapper deformity, where the testes lie horizontally. Ultrasound is helpful, but really, if you think it's this, you just want to get to help. So you can do about manual distortion. Hopefully, in 6 hours of onset, you can see the viability drastically decreases over time, so you don't have time to waste. And you do surgical distortion if that doesn't work, and you will fix the other testes to prevent that from happening there. Infection. So rather than acute sudden onset pain, we're distinguishing this by gradual pain, especially with fever. Maybe they have other risk factors. There's a couple different causes. Mumps is a particular one in children, but mainly it's from STIs or UTIs in older men. And lastly, the idea here is that we manage that sort of conservatively with antibiotics, so IM, Cef, Kef, and doxycycline, so antibiotics. So R2 probably won't get access to that management. Again, how do you distinguish hydrocele? Scrotal mass, transillumination, done. But it's painless. Think about that. Generally, if it's and the idea here is that if it was, then we want to think more about imaging, for example, or intervention. So the idea here is that again, you can do surgery, but most of the time they will resolve themselves. Communicating and not communicating, or the idea that some of them are because of the processus vaginalis being open, or some are sort of due to actual sort of issues there, so non-communicating, so like an infection, for example, or cancer. That's helpful to think about too, but hydrocele is kind of, I think, straightforward. The tumors, pathology topic, cool. But I think, again, slow and painless and in gradually increasing swelling. And they undergo periodic metastasis as well. So think about retroperitoneal mass. There's different types, which we'll talk about in a second, but the idea here is that management for cancers in quantity 3, again, you're thinking either remove it if it's curable, or chemotherapy, radiotherapy. Not really supposed to distinguish which one. Okay, so the idea here is that in an older person, we're thinking non-germ cell, so other sort of tumors that are just happen to be in the testicles, so like a lymphoma, for example. Here are the germ cell tumors. You distinguish them pathology-wise based on their histology, but I haven't included that because I think that's not as relevant for the exam. But thinking about their markers is potentially helpful. The main idea being that AFP is highly elevated in yolk cell tumors, beta HCG in choriocarcinoma, which makes sense because this is like related to the placenta. And then teratomas are negative for everything. Seminomas are the most common. Embryos are positive for everything. And that's about it. Lastly, so just some other things to think about. Varicocele, bag of worms appearance, associated with renal neck nutcracker syndrome. So that's compression of the left renal vein. Fournier's gangrene, severe infection. The patient will be very, very sick. And spermatocele, distinguish that from hydrocele because it's a painless mass filled with, and smaller. It doesn't transilluminate. Actually, sorry. It does transilluminate, but it's small, it's soft, and localized compared to fluid sort of filled. All right, last remarks. Renal is very, very cool. I like the system, but sadly for your exams, it's very weighted towards, of course, all lung conditions. And apart from that, it's really about differentiating different conditions based on approaches. Know the approaches from before, know how you would distinguish between the different conditions, and don't worry too much apart from maybe like the management of the R ones. Hopefully this has been helpful. Thank you for your time. Have a good day.